Fabian Schreif. I'm the director of the DayOne initiative. DayOne is all about building an ecosystem for healthcare innovation and supporting startups. DayOne is the healthcare initiative run by Basel area 3 Cantonal Innovation Promotion 8 in Basel. And today it's the first time that we are here on campus having this DayOne LabTalk and having the opportunity to kind of have a hybrid event format, which is a new test for us, a new experience, and I'm happy that you all joined us here today. Please make sure that you switch off your camera and also your micro. If you have any questions, just use the chat. Thank you. We as DayOne moved part of our space on campus a few months ago, and for us it's a great opportunity to be here to support startups in working with corporates and also connect them to other ecosystem partners. This hybrid event is possible thanks to digital technologies, and I think that's something that is really important during COVID times. And digital technologies, I think, can be of great value if you really make sure that it brings maximum benefit to the patient, to the customer. And an interesting experience we had was when we selected the 15 shortlisted startups for the DayOne Accelerator program. We brought them to the hospital, and for the startups, it was a great experience to learn about clinical expertise, feedback, and how to have all this clinical workflow integration and challenges that you will face in a hospital setting. And that motivated us a lot to think about how can we help startups to get faster to the customer and to the market. And that's why we conceptualized what we call validation center together with the 2 local hospitals to help startups to get access to clinical data, to expertise, and to regulatory expertise on the one hand, and ideas out of the hospital to get more insights into business model and technical design. So that's something to really speed up the process to get closer to the market and bring benefit hopefully to the patient. And today it's all about benefit for the customer and patient. But before we dive into the topic, I would like to briefly introduce our moderator of today. I'm really glad to welcome Manuel Kammermann. Welcome, Manuel. You are senior consultant at Arcondis, and Arcondis is one of our supporting partners at DayOne. It's really a great pleasure to work with you and get all your support.
Thank you.
And you brought this topic up. You were like saying us, hey, can we do a lab talk about this? Why is this topic important for you?
Well, yeah, of course, we are living in strange times right now. But even before, we saw a growing number of projects where healthcare technology was tried to be implemented. But many of those also failed. Maybe the idea was not so good sometimes, but mostly because the projects were not able to actually implement the solution that was already adopted by patients or families in the clinical routine. And this is where I realized that we need clinicians on board, that we need to understand how they work in their day-to-day workflows. And only if we manage to implement apps or other technologies into their daily work, then we will be successful with scaling solutions.
Very interesting. I'm looking forward to this conversation, different speeches and discussion later on. Thanks a lot for guiding us through the program today. The floor is yours. Thanks.
Thanks. So welcome from my side as well to everybody. I'm really thrilled to moderate today the lab talk towards successful adoption of healthcare technology. Today we're using a hybrid event, meaning we have some guests here in the room, but a large number of guests online. And you all know this is due to COVID-19. So whether you're on a mobile phone or on your laptop, or however you joined us. Let me give you a couple of instructions, especially for the digital joiners here. We have a chat online, and we would really encourage you to use it already during the talk. We are monitoring the chat, we're compiling your questions and opinions, and prepare the discussion that we can have with the panel of the 3 speakers after the talks. So get engaged, give us your opinions and questions, and let's use the wisdom that we have collected here. With that, I would like to give you a short overview of the agenda of today and also introducing our speakers. So first, and the big talk today will be given by Christine Jacob, a friend of mine that actually inspired the talk tonight. She is a digital strategist and managing director of DigiBridges. She helps her client adopting customer engagement strategies to create relevant. She has conducted a research of 171 scientific papers that talk about implementation of healthcare technology. And she has compiled the factors influencing clinicians' adoption. So we're not talking about patients too much this evening. Of course, they are important to us, but the real insights are the adoption of clinicians. This is also why we have Chrisant Salzburger and Florian Thieringer here today. Florian is the CEO, Chrisant is the CEO of Imito AG, a healthcare startup that offers a tool set of healthcare apps. And Florian is a cranial maxillofacial surgeon. Sorry, but it's too complicated for me. But together, they come a long way to implement successfully healthcare apps at the University Hospital of Basel. So we're going to cover the scientific theory, and we also have the experience of a real clinical setting of healthcare apps today. So with that, Christine, what influences clinicians' adoption of healthcare technology?
Thanks for the introduction. Thank you. Hello, everyone. Thanks for having me. Very glad to be here and very glad to talk about one of the topics that I'm very passionate about. As Manuel just mentioned, we used to work together. I used to be working with big pharma, several companies, always in digital. And one of the things that always bugged me is when we created a solution that really works, we know it's useful, we know it's easy to use, we created the evidence that it is actually adding value, but adoption is not picking up the way we want it to be picking up. So this really preoccupied me, and I started my research back in 2016. So I conducted case studies, I've talked to clinicians across Europe with several tools in focus, and I also did the systematic literature review that Manuel just mentioned, and that's partly what I want to share with you today. First of all, let's just pause for 1 second and reflect on what really makes digital super valuable for healthcare. What makes it such a revolutionary tool? First of all, those digital tools are making data very, very available and in very big volumes. That's something we didn't really have before we had those little toys that we have in our hands. We take photos, we take notes, we work, we get stuff done, and we can have this structured and continuous input of data all the time. Also, thanks to AI and machine learning, we can transform this data into information very easily. We have the capacity and the speed to be able to use this mega repository of data in a way that makes it meaningful and that makes it add value in a personalized healthcare approach. So thanks to those tools, we can have a healthcare system that's more predictive, preventive, participatory, and dynamic. And we hear about examples every day of simple mobile apps that could increase overall survival of lung cancer patient with 7 whole months. If you tell a pharma company we're adding 7 months of survival to your drug, they're going to have a feast, right? And thanks to a mobile app that just enables those people to input their symptoms constantly and to alert the physician on time to bring them if they have an irregular symptom, we are having this value that is happening that we couldn't have had before, because usually a clinician would only see the patient from one visit to another. They wouldn't really be able to know what's going on in between. We've also seen things like kids with cancer having a much more better compliance, going from 11% to 89%, thanks to a simple gamification tool that helps them input their pain journals, for example. So it starts with the data. However, if we look at the numbers, just to have some mHealth economics here, last I checked, there was about 340,000 health apps in the App Store, and that was a statistic from a couple of years ago. And there are hundreds of them being created and added to the store every single day. However, if you look at the numbers, more than half of them have less than 5,000 downloads, and only 2% have more than 500,000 active users. Actually, the majority of them would have less than 500 monthly active users. And that's mediocre to say the least, because we all know that having a mobile health tool or an e-health tool that really works is a huge investment. You really need to work on things like interoperability, if you're embedding AI in it, the algorithms, so you need to put some investment. And for 500 active users per month, that's probably not exactly a winning game. And one of the last reports from Accenture that was published right before the pandemic in Q1 this year showed that even the adoption numbers for wearables and for health apps are going down this year. So it was rising between 2014 and 2018, but Q1 this year, it's even dipping down. So what's going on here? All of a sudden, we had our little friend that's keeping us masked here, all of us, that's called COVID-19. And all of a sudden, we've seen an unprecedented surge in the adoption of those tools. We've also noticed that the countries that were the most successful in managing the pandemic were the countries that really leveraged digital solutions in the management of the pandemic. They use it for things like quarantining and self-isolation, screening and infection, the contact tracing apps that we're all using. And this, of course, is creating the sort of debate that's going on around digital health. And according to a report from McKinsey, you can see the numbers here. So a shift from a consumer use of telehealth from 11% to a hopping 76%, basically because there's a huge need. Now you have an infectious disease and people cannot afford to just show up in the clinician's office, so they need to use this thing. So we're going up from 11 to 76. From a provider perspective, they used things like telemedicine and telehealth from 50 to 175 times more than the rate they used to do it before the pandemic. 57% are viewing telehealth more favorably after the pandemic, basically because many of them tried something that they haven't tried before. And 64% feel more comfortable using it, probably because all of a sudden they had a little bit more time because they cannot bring people to the office and they can try this thing out. And even on a regulatory perspective, we've seen an approval of 18 new services in the US alone. However, there's a little keyword here that's called temporarily approving, and I'll come back to this. So the temporary piece is something we're going to discuss in a minute. And we've seen big headlines going from explosion in telehealth market due to COVID-19, coronavirus, a turning point for telehealth in Switzerland. Perspective, virtually perfect telemedicine for COVID-19. We haven't seen this that much before the pandemic, but now every other headline is about this thing. COVID-19 is driving a telehealth revolution, more diagnosis and treatment going mobile. So of course, because all of a sudden we had this new need that didn't exist before the pandemic, and more or less everyone was forced to use this thing. The big question that many of us are asking, will this continue after the pandemic? So after this thing is over, after this need is not there anymore, are physicians and patients going to continue using those tools or not? One of the key debates here about this question has to do with ethical and legal considerations. So one of the biggest issues that people are discussing are things like data privacy and data ownership, and how can we balance between the promises or the gains that we get from such tools and the risks of mobilizing them, because we're collecting such masses of data from people. And on the other hand, we had other headlines, things like telehealth can be life-saving amid COVID-19, yet as virus rages, insurance companies look to scale back, because we've seen news in the US especially about health insurance that wants to go back to the pre-pandemic quotas when it comes to telemedicine reimbursement. And that's creating a lot of frustration among physicians and among patients, because now they tested it, they know it's working, they know it's functional, it's valuable, but health insurance companies are telling them we're not going to pay for that. Another important point, agency infrastructure, IT infrastructures, are they ready to meet coronavirus telehealth challenge? So nothing really big changed on an IT infrastructure perspective with the pandemic. So what are we going to do with that? Regulatory again, removing regulatory barriers to telehealth before and after COVID-19. So all these things are also posing those questions about the continuity and the sustainability of digital health after the pandemic, and whether this is really becoming standard of care or not. So this brings me back to the research that Manuel mentioned at the beginning, the systematic literature review that I mentioned. I've been spending some years to scan through the literature to better understand, so what is driving adoption? And could just the pandemic change the whole landscape and make it standard of care or not? So just looking at that, I've scanned about 3,400 pieces. Out of them, I analyzed 171 that met all the criteria. And just starting with technical factors here, I'm not going to read this to you because I don't want to bore you to death, but I just want to show you a bit the difference between this slide and the next. So this first slide that you saw is the technical factors, are things that have to do with the tool itself, how it functions, the technology, the algorithm. Is it easy to use? Is it useful? Is it compatible? Is it convenient? Could it be personalized? Everything that we really focus on whenever we're creating a tool, which is super important. It's ABC. Without it, you cannot even go to market. No one will use it if you don't have those basics. But what was really an eye-opener to me was that the social and organizational factors were much bigger when it comes to adoption. So having this ABC is about having a functional tool that really fits, or that really works and delivers some value. But having something that fits into an overall treatment plan, or something that would fit into a clinician's workflow, is much more than the technical factors. It really goes to cover things like social and organizational factors. And as you see here, even when we're talking about clinicians, and the reason why I focused on clinicians here is not because patients are not in the heart of things. As you can see, the second bucket in the social organizational is about patient-related factors. So this whole huge bucket there with the very, very little font is about things related to the patients. But the reason why I focused on clinicians is because whenever we're talking mobile health apps that are not lifestyle apps, are prescription apps, usually you need to get the buy-in of the clinician first, because without that buy-in, without that adoption, it's not even going to reach the patient. So you need to really go through the clinician in those cases, because they are the gatekeepers, basically. So without them accepting it, it's not going to reach the patient. And interestingly enough, so the first bucket is workflow related, and we're going to go back to this in a minute, and then the patient related. And one of the things that we sometimes forget to think about is the condition of the patient. As simple as that. How do they feel? And sometimes the patients that need those tools the most are the ones that are too tired to use them, or too demotivated to use them. So that's what we've discovered in research, is that sometimes it's just as simple as that, because they have a very progressive condition and they don't feel well, unless they have a caregiver that's going to help them with inputting symptoms and with all this monitoring tools and all this stuff, they're actually not going to pick it up. So these are contextual things that we need to take into account that go beyond any sort of technical factors. So that was my key aha moment when I saw this contrast between technical factors and social and organizational factors. Actually, it's about much more than the technical features. And this was my eye-opener of, okay, so that's why actually we had some really good solutions that were not really used. So my next step was to look into all the tools, but also all the frameworks that are used to study adoption to help technology providers to create tools that would be adopted. And what are the factors to look at? And I realized that most of these are oversimplified. They basically, like the technology acceptance model, they look into usefulness and ease of use. Again, the basics, without them, it doesn't fly. It doesn't work at all. But with healthcare, you have a very interdependent system, very highly regulated, and it's a very complex ecosystem. You usually have people with comorbidities. They are treated by multidisciplinary teams, and it must fit into the workflow from one side, but also from an overall treatment plan for the patients from the other side. We need to understand, how do they live their day? How does this fit in the bigger picture? And this is sometimes not really covered with those frameworks, with those very traditional frameworks, because healthcare technologies are more complex than those tools that address one single user need. It has this complexity, this web-like relationship with everything that goes around it. And that needs to be taken into account if we want to really create tools that work. So as I looked into those frameworks, I sort of combined them into those three clusters. So I looked into the social organizational factors and split them a little bit. So I have the social and personal factors on one side, and I think that's the part that was mostly impacted by the COVID-19. It's things like personal skills, awareness, attitude, experience with telehealth or digital health in general. It's that part where we really changed. And if we go to the organizational and policy part, you have things like incentives. We now have an incentive to use this more than ever, but also things like leadership engagement and buy-in. These are also moving with the pandemic. However, there are a few things that did not really change with the pandemic. So things like the workflow related things like workload and resources in the hospitals, this did not really change yet. They still are very, very stretched. They still don't have the time to try something new unless it's super easy and it's almost invisible as it fits into their daily work. The necessary clinical practice changes, adaptability, but also things like policies and regulation. And I mentioned the keyword temporary when we talked about the approvals in the things that drove adoption during the COVID-19. A lot of those changes are not permanent. And a lot of these were just for the pandemic, and we're going to go back to the old regulations again. So what happens then? We still have the big elephant in the room. It's still there, and it didn't change. So unless we address that, unless we tackle that from a top-down approach, and we have this policy push in a way that encourages adoption, it's not going to become just a normal and natural part of standard care. Of course, as well, user engagement, and we're going to talk about this in a minute. From a technology perspective and a technical features perspective, we still have the EMR integration issue. So a lot of things are now starting to be solved. However, things like interoperability and integration, but also data privacy and security are still to be solved. So these are still biggies that need to be addressed if we want to see this becoming part of what we get as a normal prescription when we go see our physician. Otherwise, those blockers did not really vanish with the pandemic, and that surge would not continue if we keep those blockers going on. So we really need to engage users in a better way to best capture those contextual elements. Because if we don't have them at the table, it's so easy to go blindsided and not see all the things in their daily context. Let it be the patient from an overall treatment plan perspective and the clinician from their daily workflow perspective. We're not going to be able to see those points. One of the key things that bringing the users to the table changed in my personal experience is not only technical interoperability, but also what we call semantic interoperability. So, for example, one of the tools that we were co-developing with clinicians and patients it was for cancer patients, and it was a symptom checker. So it's a digital patient monitoring tool, and patients were just asked to input their symptoms on a weekly or bi-weekly basis, depending on how their clinician defines it. And when we had the first prototype, we were checking it with the clinicians, and then they said, oh, but actually the severity scale that you're using here for how severe a symptom is not the same one that we're using at the clinic. So they had a different severity scale in the clinic, which means that they would have to translate the severity from the scale you have in the app to the scale they are using for it to match the historic data that they have for that patient. So even though from a technical perspective, the two systems were communicating together, from a data perspective, a semantic perspective, they could not harmonize that piece. So it was, again, an additional work for them. So these are things you will not notice unless you invite those users to the discussions, unless you really talk to them. You might think that you have a really good solution, and it could really be, but if it doesn't match their expectations and what they do on a daily basis, you would be far from acceptance. Another interesting example is when we sometimes bring the experts and the users to the table, but we want to dictate to them what they have to think. I was working once with a patient expert, and we were developing a portal for MS patients, and it had a blog part from patients to patients. And she was that patient expert that was supposed to contribute stories about daily life with MS. And she left the project, and when I asked her, so what made you leave? She was, you know what, I felt that they're putting words in my mouth. They had those nice topics about how to travel with MS and how to go on a date with MS. But what I really wanted to talk about was when I pissed my pants when I didn't get to my key on time. That's what I feel every day. That's what I struggle with. And that's not what they were thinking about. So another point about user engagement is to have this open mind and bring them to the table when you're willing to listen to them, not just putting them at the table and telling them what they should be thinking. The last brilliant example about user engagement here is about one of the most successful diabetes apps. It had millions of users around the world. However, end of last year, they had a big issue in the news because people were using their app to communicate suicidal thoughts. So they had about 130,000 claims of suicidal thoughts in a diabetes app, and they weren't ready for it. And what their CEO said back then was, to be honest, when we started this, I didn't think it was such a big issue as it obviously is. What if they would have brought the users periodically to the table? Usually with such apps and with how fast technology is moving and how things are moving, putting it on the market is only the start of the road, not the end. It's not, oh, now it's out, as we sometimes do. Actually, it's just the start of the journey. So keeping an eye on it and keeping the dialogue with the users is key to actually keep that a success. These are just a few examples of what it means to engage users. So one of my key takeaways is that we need to really bring the users as equal partners and co-creators, not just testers of something that we assume works for them, because it doesn't always do. A few things to be able to do that is to make sure that they are present in all your lifecycle management. So all the different phases from ideation until retirement of your tool, they need to be present. You need also to have a process to capture user feedback on a constant basis. Don't wait until it explodes. and also to establish the criteria of what out of this feedback is going to make its way back to the development. Because you don't want just to end up with a nice report at your office that gives you a myriad of information that's not necessarily used to feed back into your development. Another key point is, because we have a lot of contextual factors here, success and fostering adoption is not only the responsibility of technology providers, and that's a mistake we sometimes do. We keep thinking that creating the next killer app is what's going to change the adoption and it's going to change how we do healthcare. But we do have a responsibility in three key areas in my view. Policymakers, the developers, of course, but also from an implementation perspective, from a clinics and hospitals perspective. And that's one of the things that we're going to discuss with the next speakers as well. So from a policymaker perspective, just to sum it up based on all the findings, we do need to have sustainable reimbursement and data privacy and management policies in place for this surge to sustain with us and to continue in a successful manner. We also need to have this incorporated in the typical healthcare insurance, because otherwise people will always struggle to have it reimbursed, and this is never going to foster adoption. Making sure that also policymakers are developing things like remote care protocols, because these can be different than the traditional ones. So the healthcare institutions need some support with that. Also ensure that the new skills are embedded in the medical education as part of medical students' curriculum. Funding more research to create the evidence base, because it's a bit like a vicious circle. When you go, there's no evidence, so there's no adoption. And to have adoption, you have to create the evidence, but you don't have the research. So we need more funding in that area. We also need a policy push to harmonize interoperability, to harmonize the systems. Especially in Europe, this is super problematic for any technology provider. They have to do it really on a on a case-by-case basis, because almost every hospital has a different system, which makes it super expensive and super difficult for providers. For the developers, as said, but I'll keep preaching it, involve your users and invite them as co-creators, facilitate their feedback. Make sure that you have enough training material, not only for how to use the tool or the app, but also how to integrate it in the workflow. Because sometimes, in my experience in the research, talking to clinics and hospitals, they don't always have a predefined idea of how to make it part of usual care. So sometimes some tips about this or some training ideas could be super helpful. Of course, make sure that it's useful and easy to use, and work on solving the interoperability and EMR integration. Some technologies can be more flexible than others. And one of the other things, because of the social and individual aspects of trust and endorsement, make sure that you collaborate with associations, let it be patient associations or medical associations, to gain that trust and endorsement. Let them try it, let them test it, and have their buy-in. From a hospitals and clinics perspective, the management really needs to support that cultural shift. And I think thanks to COVID-19, we had that obvious push of having to actually accept this change and having to accept this shift in a very strong manner. They also need to facilitate training programs, because sometimes the providers have the training programs in there, but the clinics and hospitals don't necessarily take the time to onboard. And I learned that the hard way when in many of my interviews, I had the interviewees asking for additional features that already exist in the tool they're using. So they're not really aware of the features of those things because they just didn't have enough training. Not necessarily because the provider didn't have that training, but sometimes because their organization did not enable that dynamic to happen. Again, workflow integration from the clinic perspective, and we're going to talk about this more with Chris and Florian when they are going to discuss their best case study. Creating new roles to support the shift as well, because sometimes you need to have someone that's just managing the data. Encouraging multidisciplinary teams exchange, because one of the key strengths of such tools is basically the exchange between those teams and offering a more comprehensive approach to people's treatment. And redefining some of the current roles. Again, in the interviews that I had with so many clinicians, and especially the nurses, was that sometimes they're given this amazing tool, but it's just on top of everything that they're doing. And the management is not taking anything else away. So even though it's creating so much help and it's creating so much efficiencies, for them, it's just an add-on to everything that they do, because the management did not exactly manage the load and the responsibilities in a way that enable them to give the time for those tools. So I hope I didn't bore you too much with that. This brings me to the end of my part, and now we're going to have the fun part with the practical things.
Always stunning how concise you can summarize your findings, and also the clear sentences you find to guide us on this path. So before we switch to Chris, I really want to thank everybody who's engaged online already. Please continue to do so. We're really looking for questions and more opinions for a proper discussion in the end of this talk. So Chris, it's great to have you on stage today as well. Tell us about your experience of implementing healthcare apps in clinical setting. Stage is yours.
Thanks, Manuel. Glad to do so. Yeah. Good afternoon as well from my side. We were also very happy to contribute to the research topics Christine was working on, and it really helped us as well to understand better from the results what we can optimize as well in our workflows. And with Imito, and now we are doing some kind of shift of the perspective from a more patient-centered view to a really view on the healthcare professionals' workflows and how to optimize these workflows with smart tools. So 2016, we started with ImitoCam, and over the last 4.5 years, we have developed a small portfolio of apps, and with ImitoCam, we allow physicians to visually document what they see. So to take pictures, videos, everything in the patient's context, to have those artifacts along ready with the electronic medical record. And beyond that, we realized, and as well with the interviews we did with the doctors and nurses which are using our apps, we integrated the possibility to collaborate based on the image series or videos which were documented with ImitoCam. So in a way, a possibility to use ImitoCam in an Instagram-like way. And based on this concept, we've introduced as well a possibility to scan documents directly with the camera of the smartphone. And this is also one use case we started to think about, because we got a lot of questions from physicians and nurses which are using or were using ImitoCam. And yeah, this usually helps us to understand these processes better, and then to realize if it makes sense to add this just as an additional feature, or to continue with the app-based and yeah, let's say use case-based approach to implement different apps for the different use cases. And last, ImitoWound, and this is the app we developed based on the feedback we received from wound managers of our customers. And yeah, it's a standardized way and image-centered to document wounds. And I will get back to that in a minute, what it means, especially if a patient with chronic wounds is not only treated by one organization. So offering apps for healthcare professionals comes with a lot of challenges, and not only the interoperability into the already existing systems and let's say the challenges in the project management when working with different stakeholders in hospitals is a challenge. It's also a challenge as a young company in general to work in this field. But from user perspective, I think we have some market tension as well. Death by 1,000 clicks is a quite bold title of an article which was published in Fortune, and they analyzed the impact of meaningful use in the US and basically focused on the results, or especially the impact which the digitalization of the electronic records or the health records had in those organizations. And what the title already shares is, of course, that not all the initiatives to digitize just for the sake of digitalization has a great impact and simplifies things. So we have this spectrum, and this is also something we learned from the discussions with our hospitals sometimes, that they are not very happy with the workflows as they are, and they're really keen on having some simple tools which are simplifying their work as well. So we have this part as one of the challenge. And on the other hand, we use apps every day in our private life. So we are really used to the simplicity, the usability gain we have for specific use cases. We are using those apps. So this is as well the expectations healthcare professionals have when they're using clinical apps. So bringing those ends together in simple apps is a challenge for us, and this is our passion as well, to drive that forward and to enable healthcare professionals in the clinical routine. And before we started, just some foundation about Imito. Or when we asked in a survey if smartphones are already used by healthcare professionals in their clinical routine, more than 50% of the doctors who work in a hospital confirmed this basically. And when we asked if it would be useful to collaborate with each other, more than 70% confirmed that this is essential to collaborate with colleagues and to get a second opinion, for instance, on a case they're having a question. And of course, to have it integrated in the already existing environment. So no additional isolated solution. So when I read this statement, I realized that we already came quite far with the hurdles to overcome in the, let's say, with the apps in the clinical context. And of course, it's our motivation and passion to simplify the work, but to read that it's fun to use, it's quite extraordinary for us, especially as founders of Imito. And over the last years, we had the chance to work with a quite steep learning curve in different projects. So to have onboarded now more than 25 hospitals with our apps, and having the Sana clinics in Germany as a strategic partner and which is feeding in as well. Besides, of course, the existing customers, bringing in new ideas and new topics to further develop. So coming back to the app portfolio and to ImitoWound. So chronic wounds are treated not only by one organization. So it's crucial if organizations want to collaborate with each other and don't want to start from scratch with the documentation and with its terminology. It's crucial to use standardized terms and to have semantic interoperability in place, which is not the case in most of the cases where we are rolling out ImitoWound. And as mentioned in the beginning, we've developed ImitoWound with the feedback we received from our ImitoCam users and allow them to use it in a secure and compliant way, have wounds automatically measured, and with this information, a more objective documentation. And to allow the use in a clinical routine with the app on the bedside work, and to have as well a integrated view of our web application directly in the cockpit of the EMR. So to have a seamless experience, even if it's an additional tool, to have it in the same cockpit where all the other information is accessible. And here to mention as well, with Smart on Fire, this is going into the direction that and that it's becoming easier for app developers to integrate in a seamless way into already existing systems in the hospital especially. So with ImitoWound, we also started to offer as well a cloud version besides the on-premise offering directly for the hospitals. And it's for us a way to learn as well from two different caregivers or caregiving sets. So to get feedback as well from smaller practices. And we've started this year, and I think this is going to be another journey, or let's say a way to learn further from different caregiver settings in the market. So I'm very happy to answer then questions in a panel discussion, and that's it from my side. Manuel.
Thank you very much, Chris. Yeah. So, Florian, thank you for finding the time to join us today.
Hello. Thanks a lot for the invitation. It's a pleasure for me to be here.
And as it is for a surgeon, you didn't bring any slides. We're doing this in free form.
Exactly.
And I think this is also showing how much we are in the real setting here.
Yeah. Well, to keep it short and to have more time for discussion, I would like to report a little bit what the benefits could be actually of a digital tool in your daily workflow. And that's something what is for us as surgeons, as you already mentioned, is very important. We are very visual guys. We work with a lot of patient data, images that are stored, usually were stored on cameras and private mobile phones. And with Imito, we had the chance to get this immediately in a patient record. And that was for us the motivation to continue with this idea and to collaborate with Imito.
Okay, interesting. Maybe it's just me, but for me this sounds very logic, right? It's ease of use. But maybe elaborate a little bit. What were your challenges before you had Imito? What were you struggling with handling all these images in the day-to-day work?
Yeah. I would say it's in my years as a trainee or young surgeon, as surgeon in the emergency department, we actually had a camera which was reserved to document the images for the clinical use. And this camera was equipped with a chip, and you took the photos. First, you had to search for this camera always, because it was not always there where you estimated where it could be. And this camera was used to take the photos of the patients, and we had to take out the chip and to walk to a computer station and had to upload the photos. Already we had at this time electronic health record. So we had to upload with a very clumsy app those photos. And of course, you also had to take a photo of the patient information, because you were not always during the treatment process able to take the time to upload. So the whole process was really, really time consuming, not very convenient. And you had the risk that the wrong images were uploaded to the wrong patient. So for us, there was a huge need to improve this whole situation. And with mobile phones, which every surgeon uses in more or less or every medical doctor uses in the clinic, it's quite obvious that you use the camera and you upload the photos in the patient record. But this is only one part of our work, and we always seek to, or we're looking for solutions how to improve our workflow, and therefore I think this app is a part to improve our daily work tremendously.
Okay, thanks. Sounds like technology development really played into this and gave you an advantage in optimizing your workflows. Then again, what we heard from Christine is that there's more than just technology advancement, right? So it's not only having these new smartphones that you can pick everywhere, their batteries last for hours, etc. When I think of multiple people joining such a tool or such a workflow, maybe your team grows over time. I guess it's also a challenge how the different requirements of everybody, of every individual, is then kind of incorporated into this, right? You told me before the talk today that you were traveling around and you needed to look at an image. So how did this evolve, this growth of the team, maybe the specialization in the use of these images, and just the grow and the implementation in the workflows maybe?
Well, this is, of course, you're right. This is something which is supported by digital tools in your daily workflow. And therefore, I think the University Hospital of Basel tries to implement as many tools, digital tools in the workflow to improve the daily work of the doctors, and also to improve the treatment of the patients, to be patient-centered, to provide the doctors in there and of course nurses and any healthcare professional who's involved in the treatment process to improve the treatment. And therefore it's with digital tools much easier to improve and also to integrate in existing workflows already. So if you have something which, from our perspective, from the problem-based perspective, if you have something that makes life easier, then you can easily adapt it and use it in your daily life. I think this is the most important thing. And Christine, I think you identified it correctly, that you also have to take care that the tools were not implemented and without the how can I say, integration of the ones who should later use them. So you have to ask how can we improve your workflow? How can we make life easier when you have a new tool? So it needs to be accepted, and it needs to make the life easier in your clinical workflow. That's I think very important.
I see Chris nodding in the background there, yeah. So I guess there's some common history about that. So when you think about the work you've done with Imito, and especially this aspect of understanding how the people work in the clinic, is there something that you can say that you really like about the way Imito went ahead. Maybe it's not universal to them, but something that you maybe experienced only once Imito joined, or you actually participated in the survey of Christine's work.
Yeah, well, the Imito is, I think, in this case, is quite unique to us because we were a very early development partner. I don't know, maybe we were the first development partner. So we as doctors were involved in the development process, and they listened to us and our needs and tried to implement this in the software. So for us, it's the perfect situation that you can ask for something and it will be more or less integrated if it makes sense. So therefore, it was really user adapted and needs adapted, and at least for those who were involved in this process, it's a tool that can be used on a daily basis and improves the workflow tremendously.
And that's, of course, I guess, easier than just buying an off-the-shelf tool that has its own workflows and ideas of how to work with it and then adapt it.
Well, if you have something that is really a game changer because you notice immediately that this product will improve your daily work tremendously, then it can be. It doesn't necessarily needs to be adapted to the needs of the user, because then you already have a solution and it's a benefit. But to reach that certain point in medicine is not that easy. That's quite clear. Yeah.
Great. Thanks for sharing your experience. And
thank you.
I guess then, Fabian, we can move on to the panel setting, right? Thanks. So please take a seat. Of course, we keep safe distance. And let me check if we have questions. Yes, they're floating in now. Great. So I guess ladies first. We have Stefan Ritti, who's wondering how designers could help to make the change happen. The issue that you described sounds very close to what design solves. And we asked back what if he can give us a bit more context. So I mean, he means using designer methods to emphasize a holistic challenge and bring solutions to be tested. If you think about design thinking, human-centric design, etc., user experience is also a facet of that.
Yeah. So what I've done with the aggregated framework is I have actually looked into the frameworks that study user acceptance, and they are usually used in design afterwards. And this aggregation goes beyond what most of the frameworks actually do today, because they focus more on the solution itself, but not the context, not always. So what can be done is basically really active user engagement and ensuring that the users are part of the dialogue on a constant basis. So before going with a demo, listen first. So go there with a blank page and just listen to what are the pain points of those people. What do they face on a daily basis? Because sometimes they can give you ideas you haven't really thought about. So before going to test the demo, just start by listening, and with a very open mind, just listen to what they face on a daily basis, what sort of solution are they looking for, and then test whatever you're testing with them. And this way you can capture much more than just going and forcing sometimes an idea and just ending up testing something you think is going to work. You're going to test it pretty well. You're going to find the pros and cons. Perhaps you're going to develop it further, but you won't necessarily find out what you might not have thought about since the beginning, because you're going there with the intention of testing something that's already a prototype. And I think that's the difference in the approach that I suggest. It's start the discussion with a blank page. Just listen and let them talk, because sometimes you're going to capture things you might have not really thought about when you're going just with the intention of testing thing that's already ready for testing.
So what I hear is designers are a crucial part of the
Definitely,
solution,
yeah,
actually.
certainly, yeah.
But they should also focus on listening to the customers.
I'm a big
right?
fan of listening.
And I see Florian nodding, Chris as well.
Yeah.
So I guess good news, Stefan. Designers are a crucial part of the solution. So
Maybe.
get out there and help.
Yeah.
Yes.
Yeah, I think these designers are a crucial part in it, but maybe it's also a definition how this profession is described. I also think requirements engineering, which is the profession I would describe this, or what I see it most as a part of the profession, to really perform those context interviews and not to jump into something and presenting something and bias the user in that sense that they think, oh, okay, yeah, that could be useful, but rather, yeah, as you described, to take one step back and describe the context and then start to come up with solutions and then test it. Yeah.
Great, thanks for that comment. Our next question goes to you, Florian. So what cooperation between different functions in the hospital had to happen for adoption of Imito solution in the Unispital Basel? Can individual physicians just go ahead and use Imito, or did there have to be a buy-in from nurses or other functions? And what are the pros and cons of both situations? So a lot of questions. I'm going to break them down for you.
Oh, maybe for the very beginning, I can answer that question already. It was a collaboration with our IT department, and they're quite, in my opinion, quite innovative and open to solutions. Of course, the doctors came with a need, yeah, and therefore they saw that there is a group of quite tech-savvy doctors who could be implemented in a project, and in this case, the development was done with some test users and a test group to work on this app to improve the let's say the photo handling in the daily clinical work.
So it was basically not only you going ahead because you had a specific need, but you also had to collaborate with others, find common ground, and then go as a group of people.
Yeah, well, I see Imito is a perfect example for a solution for a problem, because as I think we saw in the presentation of Chris that a lot of doctors, and I think if you have a study done with surgeons, for example, it's even more than 56 or 60%. So I think every surgeon more or less takes photos in the daily work. So that's a problem, that it's not structured, it's not safe. Of course, that's also a problem. And I think for this, this app was a very nice solution, because we were able to use, and at the university hospital, we have also a policy of bring your own device. So the device is managed by the university hospital. So you can use even your own mobile phone, and you can upload patient-related the data without having to store them in your photo database. So it's completely separated. So it's also from security aspects a very nice solution for a problem which existed, because I don't know if you have seen already a photo of a doctor or a surgeon where you see some children's photo, family photos, and then a wound or whatever, a broken leg, and then again photos of the family. And this is something we would like to avoid. And therefore, I think that was a very nice solution for an existing problem.
Yeah. That actually happened to me lately when I walked by a colleague that was working for a dentist, and he had some use case images, and I was like,
yeah, sometimes not very nice to see them. Yeah.
So Chris, maybe from the other side of the project, what was your experience having to manage different stakeholders that, from my perspective, probably had different requirements towards the solution?
Actually, for us, this was let's say, motivation as well to work with the University Hospital of Basel. Where we're really happy that the University Hospital of Basel told us that they are interested to cooperate as an early adopter, because they had a project manager on the IT side who was as well working with the business side, with the physicians and nurses, and this really helped to go quite quickly from a idea stage which we pitched to them basically, and I thought, okay, this could solve a problem, to a validation that it can be actually used in the clinical routine. So for us, it was as well a perfect starting point, and we were really surprised how quick it was going from this idea stage to the adoption stage, when we are comparing it now with other hospitals where we are adopting, and where it still sometimes take quite a long time, even with a product we are now offering off the shelf in that sense.
Yeah, so were there actually a lot of different requirements in the different areas that you implemented the tool, or when you look back at it now, you're like, oh no, maybe everybody uses the same processes?
Yeah, very good question. And I've shown or presented that we have now 3 different apps for 3 different use cases. So we tried to avoid to add too many different things to one app, so to keep it simple and focused. And that's why we've decided as well to keep ImitoCam, for instance, a generic tool which can be used by almost all the different disciplines in a hospital. So University Hospital Basel, I think, is using it in 30 different areas today. And ImitoWound is on the other hand quite focused on a specific problem, but they have additional requirements, and for them it's a standard operating procedure in that sense to document wounds in a specific way, which is not important for a surgeon, for instance, on the other hand. And they just want to snap and forget about it and have it in a secure and compliant way stored. Yeah.
Very well, thank you very much. I think the next question goes to you, Christine, and it comes from Rasmus Feld. You mentioned a lot of different factors that influence adoption. If you could improve only one, which one would it be?
That's a pretty tough question. I think one of the key findings of the whole research is that it's very contextual, meaning that you do have to take the context into account. And this whole myriad of factors that I've presented are pretty much the ones that would cover more or less everything. Now, for every case and for every solution, there might be one factor that would be a game changer, and it might not be the same for every solution. Because, for example, if I say, well, the big elephant in the room is data privacy or interoperability, you know, the big blockers really. Sometimes you might have a clinical decision support app that doesn't necessarily store the patient data. So data privacy wouldn't be your issue here. So it would be the wrong pick for that one. But maybe something else could be the one game changer for that tool. So I think one size doesn't fit all is an important takeaway. So don't look at all this huge chart of factors as like all of them would apply for every single case. That's why you need to do your research for every tool, because it's not just one thing that you're going to throw and it's going to magically work. It's really it's really giving you a helicopter view of everything that's relevant, but then you need to identify your one thing for your specific solution. So I think I can't really give him one, but it's really, there could be a couple of factors that are game changers for each solutions. But still, think about the context. There usually is more than one factor. And that's why the aggregated framework says that it takes into account the context, because the difference between healthcare and the other tools that usually address a single user need is the context and the interdependencies. Usually you have people with comorbidities. They're treated by multidisciplinary teams. And if you don't look at that complexity and take it into account, if you try to oversimplify, you might very well overlook very important factors.
But then again, I also understand this as a moving framework, right? Depending on whether you just start implementing a solution or whether you are in phase 3 and are about to have the third version of it. It really all depends, right? Maybe with one step you get the user experience improved, but then you maybe lack one of the other factors and so on. Then you work on those, and really as the app or software basically goes along, you have to manage multiple factors at the same time constantly. And maybe there's others. So it's really not a on-spot problem-solving framework, right?
Definitely, yes. Yeah. So it really gives you the spectrum, so you don't overlook any important elements. But you probably will start with the technical factors to have a minimum viable product. So you will start with making sure you have a car that's running, right? And then you start looking into like the color, is it metallic, is it not? So will I put an AC, this sort of stuff. So you start with a core, with a minimum viable product that looks at the technology, interoperability, does it communicate with other systems and so on. But then once you have this little thing that would attract some user to start with, you need to then understand the context of the user and what would really make it work for them.
Great, thank you. I hope that answers your question, Rasmus, and if not, just give us another post and I'm happy to follow up on this. So for a change, we have a physical question here in the room. Doug Hagström, please.
That to be the first physical question. A question, well, first of all, a comment. Great to hear that our friends at the University Hospital Basel are somewhat unique in their openness. But a question now, about reimbursement and getting them to pay for you. How are things, what's the business model behind Amito now for either the hospital in Basel or more generally, what's your real go-to-market strategy? How will you pay for yourself?
Yeah, very good question. And we offer our apps for the hospitals usually in a subscription-based model. With University Hospital Basel, we have a different agreement since they're an early adopter and a development partner, but that's usually the case. So we have one fee for the integration into the hospital systems in general, and then we have an app-based fee, like an in-app purchase, but in a direct contract with these hospitals. So there is unfortunately not a, or maybe it's fortunately, yeah, it depends. A model like the DIGA model in Germany, where it's a reimbursement by the insurer. In this case, it's really the hospital who's paying the fees at the moment. Yeah.
Is there any hope to get it reimbursed at some stage with insurers or part of the model, or will you always just be part of the hospital cost infrastructure and making Florian's a happier surgeon, and that's the argument?
With a more let's say we are now involving or offering our app, especially into wound, for smaller practices, and there we really need to iterate, it seems, to find a good fit for the reimbursement for the practices who are using the software, and there we are as well having a close look how it develops in Germany, especially with DIGAs, and to see if it makes sense to pivot in a more patient-oriented app to have or to benefit from a reimbursement via the insurers. But yeah, that's steps we are currently looking at. But yeah, thanks for the question.
So from the doctor's perspective, I think reimbursement of innovation is a huge topic, and we can discuss a whole evening about that. But unfortunately, the insurance companies will not pay, especially for the use of an innovative software. But of course, we see the benefit in the improvement of the treatment process. And the time, for example, we can save when we use a specific tool or software that helps to treat our patients better and faster, that indirectly, of course, reimburses itself. So therefore, I think this could be an answer to your question regarding, for example, on calls when you have a senior at home and the junior doctor sees the patient, and usually the senior had to come maybe in the hospital because to support the doctor and to see the patient as well. Nowadays we can submit photos, we can submit computed tomography scans, and we can discuss everything by the use of a digital patient record. So this is something which nowadays improves our work tremendously, and therefore I think it's also for the hospital attractive to invest in such tools. So that's, I think, a kind of reimbursement.
A happier chef arts who isn't coming in on a Sunday afternoon, I'm sure is worth a lot of money.
Exactly, yeah.
So there's two more questions. I will paraphrase one for actually the entire guests here, because I think it's more a question that is not directed towards a specific speaker, but Katrin says, thanks for the answer about different functions involved. And she says, if there's only a limited stakeholder group that is implementing something that they're already doing, maybe this is a good way to start. We have a clear focus, we have a clear set of requirements, and if those are aligned, that's maybe a good setting to start implementing healthcare apps.
Maybe I can say something or comment this, because I think it's always a kind of balance between individual solutions and something that works quite well as a, how can I say, monolith maybe, or something which is for everyone. So, because if you have too many solutions for individual groups, that can also, let's say, make the processes very slow and the integration even more difficult. So, of course, I think this approach can be attractive if it's a very, let's say, visionary solution, but sometimes it can be also very difficult to implement this in an already existing setup of different applications.
That's interesting. So, question to Chris. Is the number of apps you're going to develop limited because you don't want to grow too big and too complicated and implement processes that are getting too slow?
Yeah, I think this is a question which we need to ask ourselves quite often, and especially since it's becoming a more and more dynamic market with different providers. If we look at it, and especially the different use cases in the hospitals where solutions can be developed for, more as an ecosystem where there is a master patient record somehow available, which allows an integration and consuming of patient data, and offers quite specific apps for the different problems or the different stakeholders. I don't think it's really limited in the number of apps which can be developed for one ecosystem, if you say it's a health region or if it's a hospital as the ecosystem, and there could be also similar solutions, and one is used for one department and the other one is used for the other department, as long as it integrates into the already existing data and as long as it's standardized and the results are also consumable by the app of the other department. So how we see it in let's say, the app stores more and more nowadays. So yeah, for us to answer the question, it depends a bit how it develops, how fast we for instance, see HL7 fire in the hospitals on a regular basis, or becoming the standard, basically. And yeah, then I don't think it's really limited to the app use cases we can come up in the future.
Great, thank you. So this is also an interesting question, I think, especially targeted to you, but I would also like to hear your perspective on it, Christine. Satish Kumar Reddy is asking how open the USB is to collaborate with startups, not only in Switzerland, but also abroad, also in perspective of relevant data sets to improve such tools.
Well, this is actually something I think the IT department of our university hospital has to answer. But to my experience, they're quite often in having those kind of development collaborations. If you have a interesting tool that can be or is very, let's say, visionary and could be a huge win in the daily work, then I think that's something that could be offered to the IT department, and they will evaluate it, and maybe it's a kind of development collaboration that will be the solution to collaborate. I think that depends on the tool, of course.
So when there's relevant data or apps,
sure. I think
USB is quite open.
Exactly. I think one of the important parts or pillars of our strategy is innovation. And if there's something that could improve our daily work, why not invest in a collaboration? But this is actually something which is highly dependent on the use case.
Absolutely.
So it's not like the second emito or the third emito that would be of interest. So I think that should be something which is of a highly use for the surgeons, for the medical doctors, for the nurses, or the people involved in the treatment of our patients. Great. We have actually, that's something maybe I can add. We have something which is called Future Friday, and this is actually mainly for people working at the university hospital. But if they have a brilliant idea with focus on an innovation, they can work on a very small proposal, and they can pitch and can present it. And if it's worth that, we have a committee, and they will evaluate. And if it's worth to invest in it, usually it's possible to get a certain amount of money so that this product can at least, or this whatever, can be developed for a certain time, or you can invest some money for that. So maybe that would be the approach to work on a new app, for example, to find someone working at the university hospital and to pitch for Future Friday.
Thanks for that insight. That's super interesting. Now whole LinkedIn is going to get flooded.
Let's see.
So, Christine, your perspective on data. I think if you look at your whole framework, data, especially when we talk about algorithms, clinical decision support, do you have a place for that in your whole framework?
Yeah, data can be a topic on its own. It's a very complicated one because it has some legal aspects to it, and laws can be different from one country to another. So back to the question of collaboration, depending on where that app resides, you might be concerned about data privacy that feeds into that app, right? So you want to make sure that your local laws are respected when it comes to someone maybe operating in India or somewhere that have different laws when it comes to data privacy, but also things like data structure and the nature of the data being fed into the systems themselves. And one of the famous examples I always bring up is the day my husband came back, and he's a physician, and he was like, yeah, I had to do a clinical trial and I have to sign every single paper. And he had that stash of papers and he had to sign each of them. But then someone transferred it into an electronic version. So he didn't sign electronically because he had to sign that. But the electronic version was a PDF. That's not searchable. It's not aggregatable. It doesn't speak to anything else. So it's the structure, it's the form of the data, it's the harmonization of the data. So even going, like further after talking about legal and data ownership and all these sort of stuff. So how do we make sure that this data is harmonized? Going back to the semantic interoperability point that I brought in the presentation, how do you make sure that the data that's being fed into the system is harmonized in a way that it speaks to each other? It's like the data, for example, that's in the EMR has a specific structure, but then the form that gets sent to the insurance for an MRI, for example, it would have a code number. So it's even different in format. So it doesn't have the same shape. They don't really speak together. You have to search for that code to put them together to make your research. Also, the way the EMRs are being set in many ways, it's customizable in the hospital. So every hospital created their own categories. So if you want to do cross-hospital collaboration, again, you have data sets that cannot be merged together in a way that gives you a solid big picture where you can really bring the potential of this data. Things like anonymization, the effort to be put in anonymizing this data to make it legal to use it needs an investment in time and money. And there's no incentive for hospitals to put time aside and money aside to do that, to anonymize huge amounts of data. Then you have things like bias, data bias. We hear about the amazing clinical trials that the iWatch is being used to do, but what sort of economic structure is behind that? Not everyone can afford an iWatch, right? So you will have a nicely biased data set that's going to give you excellent results, but are not necessarily applicable to everyone. Then you have the ethics and AI bias and a lot of things that come into this data management thing that we can do a whole talk about. I don't know if I forgot anything, Florian, that you'd like to bring about data.
I think you're really right. I think the key is really that the data is structured. Otherwise, you can really throw it away. It's like collecting huge amounts. If the data is not structured, it's useless.
Yeah.
So I think this is really the key to success.
Yeah.
All right, thanks for that perspective. So I guess we're approaching closure. I'll have Fabian ask a question, right? And then we'll close with a question from the capital region of Denmark. No question. Good. So the capital region of Denmark, and I think it's a question directed to Chris first, but then I would also love you, Christine, to summarize a little bit, and Florian as well, which will make a fine closure for today. So the capital region of Denmark has a number of health tech solutions that are stranded or suffering pilot death. Projects that fail to progress from the early pilot studies, even when they manage to provide the evidence that the solution brings value. How did Imito manage to progress? When were the hospital, procurement, and other parts of the administration involved in early testing and development? So what they're probably looking for as a general is, again, a summary of what we've heard this entire evening from an implementation perspective, from the scientific perspective, and from the clinical setting. So, Chris.
Yeah, it's a big challenge. So to let's say survive in that sense as a startup in this healthcare sector. So to continuously stay in contact with. So it's a lot about building a product and being able to find additional customers, not only work with let's say a first pilot hospital on it, but to find other hospitals which are then picking up and are multiplying what you've invested into into the development, and that's still a big challenge for us, to be honest. So to especially in this slowly adapting or quite often slowly adapting an environment, and I think we had as well quite some luck in this process to really find the hospitals which are ready to adopt and to understand as well the needs of a small company when it comes to procurement, etc. So sometimes you really need to be to stay in the contact with those hospitals and to not just go away if you get the first no from one of the hospital and continue and be persistent and insistive when it comes to sales as well. So I think it's one part is really to come up with a problem solution fit, and if you don't have it, iterate further to find a better fit, and then to find others with the same problem and then to offer it.
Thanks. I hear a lot of persistence there. Christine.
So I think, again, one size doesn't fit all. It could be a collection of some of the factors that we have seen today. Some of the biggies they need to ask themselves in a case-by-case basis, is the tool interoperable or not? So it's not creating one efficiency on one side, but then throwing it out of the window on the other side when the nurse has to, rewrite everything again in the system. Is it something that's smoothly aggregated or integrated in the workflow? So as they say, the best solutions are usually the invisible ones that almost are working without you noticing that you're even using another tool. Is it reimbursed? Because in most Europe, we have public hospitals that are running on deficit. So sometimes if there's the fund is not there, so some hospitals are lucky to have those innovation funds and they have the management that's leading such adoption. But if it's a smaller hospital maybe that doesn't have that extra fund, if you're not reimbursed, this could also be an issue. So it could be a myriad really of factors, and they need to look at those big things that could stop the adoption. It could sometimes also be the lack of decision-making process or the lack of selection criteria inside the hospital. And surprisingly, as silly as this sounds, this seems to be a mega issue in most hospitals and clinics, because usually it's really a multidisciplinary team that comes to place to take such a decision. You have the finance team to say we have the money. You have the IT guys to say, yes, this is going to work with our system. You have the medical doctors to say, yes, this adds value to my patients and to me. So not every hospital actually have this working in a harmonious manner or in an established way, because there is no real process really for what do we need to do when we want to bring another digital health solution. I think in Uni Basel, that's a really good best practice example, because you have this innovation unit and you have people that are leading the effort. But in some other hospitals, in many actually, in the majority of the ones I've talked to, they don't have an established team to take care of those selection criteria or decisions. And that makes a lot of those startups struggle. Who do I talk to if I want to introduce my solution to the hospital? And would that person have the gravity and the weight to champion it and bring it to the hospital or clinic or not?
Thank you very much.
So I will keep it short. From my perspective, I think it's a mixture of a lot of different factors, and at the end you need a lot of luck that with your startup and your app you will succeed. So actually this is very important. and as you already said, that's very important. Start from the need and do not come with a solution for a non-existing problem, for example. You have to ask the people who work with the patients, and if you really improve the daily work, then I think you have a good chance to implement your solution in the clinic, for example. That's my opinion.
Great, thank you very much. Fabian.
Wow, very insightful. thanks a lot to Christine, Florian, Chris, and Conrad. I learned a lot. I hope you too. Please let us know what you think. We will send you a survey about this event. We would like to know what you liked, what we can improve. I think we will hopefully have a next DayOne Lab Talk. If you have a topic you're interested in discussing with our ecosystem, please approach us. And we hope to welcome you again on September 30th for the next expert event. And please already put in your diary the Health Hack and the DayOne conference in November. 2 highlights definitely not to be missed. Let us know what you think. Thanks a lot for joining and have a nice evening. Thank you.